I think we can
A
start, Matt.
A very warm welcome this evening to everybody to our next webinar in our Emerging Clinical Techniques webinar series. My name is Matthew Garrett and I'm the Dean of the Faculty of Dental Surgery at the Royal College of Surgeons of England. I would like to formally thank Jag Danda, who chairs our Postgraduate Education Committee, and Jag, together with Fatima Bolbulia, who is our Head of Education, has put together this series of webinars. We will, of course, be very pleased for your feedback on the topics that we've chosen and any future topics that you think would be of interest to you. So please do let us know if there's anything you think we need to consider. At this point, I would like to hand over to Jag, who will introduce this evening's event. So thank you very much, Jag.
Thank you, Matthew. It's my great pleasure to introduce Dev Patel, who is a work colleague that I worked with, and the reason why I've invited him is because I'm on one of the WhatsApp chat groups, and he always seems to get wonderful feedback from any of the attendees of his courses. So Dev graduated in 2004 and completed a full-time MSc in Conservative Dentistry at the Eastman Dental Institute and was awarded distinction and postgraduate prizes for excellence in both clinical and academic achievement. And during his professional career, he's developed a great interest in restorative dentistry, particularly in relation to implant dentistry. Special interest is severe tooth loss, complex fixed and removable prosthodontics using implants and full mouth rehabilitation. He's a visiting lecturer at the Eastman Dental Institute for Restorative Dental Practice Programme. Numerous courses on occlusion, including his own occlusion masterclass, and hands-on courses which he teaches principles of full mouth rehabilitation, including both conventional and adhesive techniques. And he's launched his own online course in occlusion as well. So great pleasure to introduce you, Deb. We look forward to hearing you, your presentation, and then there'll be a Q&A at the end of the 45-minute presentation. So over to you, Deb. Thank you very much.
Thank you, Jag. Thank you for a kind introduction, and great to be here. It's a pleasure to present and speak. So let's start with the presentation. So today's topic is simplifying occlusion, and mainly in this next 45 to 50 minutes, I would like to give you guys some of the practical tips which you can go tomorrow to your clinical practice and start applying it, because occlusion can be quite daunting, and when we start looking into it, you know, we can go very deep into it, and you know, I run 4 weekend course and still it's not enough. So today's topic is anterior restoration. So we're going to discuss about how you're going to apply some of the principles you learned today in your clinical practice while you are restoring some of the anterior teeth. So the aim is to understand the importance of occlusion in general dental practice and application of occlusal management in anterior restorations. And one of the great tip I learned while I was learning and studying occlusion is how we can really change protrusive and lateral guidance without really reorganizing patient's occlusion. And we can tweak it. We have really good materials nowadays, and I'll go through some of the one full case protocol and how I do it to make your anterior restoration last longer. So before we look into anything, we need to look why really, you know, people keep banging on about occlusion. And I mean, I teach quite a lot and about occlusion, and you know, most of the courses do mention about occlusion, but we all know that it's very important, but it's very difficult for many people to contemplate how important it is and how it affects our day-to-day general practice, because many times dentists think that occlusion is only relevant when you're doing full mouth reconstructions, when you're doing complex cases. It's actually more relevant when you're doing general dentistry. So I would like to ask you 4 questions. The first one is, have you ever had to sort of overcarve your filling or trim your fillings when you're doing, you know, molar restoration, single tooth restoration, because it was too high after you remove the old restoration and you're doing a new restoration? Have you had a situation where, you know, you prepared this second molar for a crown and the temporary keeps coming off, and the final crown came in, it was so high that you are really grinding it down, and at the end it perforated. And if you practice long enough, you will get caught up by cases like this. It doesn't happen very often, but very often you end up preparing or adjusting your final crown of the second molar if you don't take precautions. Or, you know, we also all seen patients who have repeatedly breaks or chips their restorations, and we all come across that. And of course, we all want predictable restoration, so we want all our restoration to last predictably. So, and this is the reason we need to know about occlusion. Occlusion during function, like eating and chewing, is not as important as we think. Occlusion is really important when patient parafunctions, and everyone parafunctions in their lifetime, sometime or the other. Some people do more, some people do less, but everyone parafunctions. So let's look at some of the differences in function and parafunction. So as you can see that the duration of the contact is massive when patients parafunctioning. The force is almost 10 times more than what you can apply during the daytime. But the main reason it is more disruptive is because the direction of the application of the force. So when patients functioning, it's more vertical, whereas patient parafunctioning is more horizontal or lateral, or in eccentric movement. So it goes everywhere, the forces, and it could happen in some of the weirdest position, because that's where patient's jaw goes when they are parafunctioning. And the lever, we have very weak lever action when you're doing function, which is class 3. That's less disruptive, whereas we have class 1 or class 2 lever action when patients parafunctioning. The muscle is different. Proprioception is less when patients parafunctioning, because that happens subconsciously. And again, the closer position is different in function versus parafunction. And this is a great example. Now we can debate on this tooth, one particular photo for a long time, you know, but let's look at some of the issues with that tooth. It's the last tooth in the arch. Obviously, it's got vertical fracture, but the reason it has vertical fracture, we can always discuss different reasons. So one of the reasons is it's got amalgam. And amalgam, we know that can cause crack in the teeth. Certainly, I've restored so many teeth with amalgam, and every time I remove amalgam, I tend to find cracks under amalgam or running around the teeth. But if you look at very carefully, you can see in the middle of that amalgam, you see a faceting. Now, that faceting is caused by obviously opposing tooth, and it's quite pinpoint, and that can suggest that it could be first point of contact. The other thing you can see here is on the palatal cusp, you can see that there is another faceting there. And again, that could be a non-working side contact, or it could be patients guiding on that palatal cusp and running towards the buccal on a lateral excursion, and that can cause this crack to spread and break the tooth. And obviously that tooth had to be removed. Now, this is the case actually we are going to go through in detail today, and how I managed this case. This patient actually came to see me because his tooth was prepped for front for 3 veneers, so upper centrals and upper left tooth. I'm not sure why upper right tooth wasn't involved, but that was the reason. And then patient keep breaking the provisional. So the dentist changed that veneer into a crown. And then the patient decoronated that crown. Then the dentist went ahead and put a post in that tooth and put a temporary crown, and patient decoronated that as well. So literally broke the post. And this case came to see me, and I'll show you how I treat it. But this is quite often happens when we ignore occlusion. It doesn't thankfully happen that often that patient is that kind of destructive forces, but you can get caught out by it. So coming back to occlusion, why it is so confusing, and I found few reasons why it's confusing. It's not very well taught at undergraduate level. There has been actually a recent study in 2018 done where they asked universities how many modules they have on occlusion, and most of them, they didn't have a separate module on occlusion, and occlusion was part of the different fields. So, you know, if someone's teaching crown preps, they would go through occlusion about the crown preps. There's no separate module on just occlusion. And the hours which were the university which had separate module, they didn't have enough hours to teach occlusion. And that's why many times when dentist comes out of undergraduate, they are less confident. There's also too much information. It seems very difficult to relate clinically because, again, occlusion is something you learn as you go along, and you can't really attend an online lecture and learn occlusion. If you attend something, you really have to put that into practice. If you don't put that into practice, then you don't learn from the experience. There are lots of different opinions, and you know, everyone has opinion about occlusion, how to manage it. However, there is not enough scientific evidence to support different opinions. So there is no scientific evidence to support one particular way works better than the other particular approach. And because of that, it gets all confusing. So for that, the advice I have is try and follow one particular way to deal with the occlusion. Make sure that the person who's teaching is experienced enough, has done this before, and try and follow one strategy first. Once you master that, once you practice that, then branch out onto different, because in my experience, there is no one strategy which works better in all patients. So, you know, if you learn canine guidance, it doesn't work in all the patients. There are different scenarios where you have to go group function. There are scenarios where you have to go balanced occlusion, not definitely in full mouth teeth reconstruction, but the other reconstruction doesn't involve any teeth. But and there are situations where you have to do progressive guidance. So there are different ways where you have to manage occlusion. So, but try and learn one approach first. And the canine guidance, sort of a gnotology-based occlusion is, in my opinion, is the simplest way to start learning. The other confusion is there are different terminologies to describe the same situation. And many times people get confused. And just to give you an example, this was a recent article I was reading literally last week, and someone wrote a really beautiful article. It's a really good laid out and a very good article. If someone doesn't know many terminologies of occlusion, to learn that. However, the person has written centric occlusion / in maximum implacable position, and what it looks like here is the same. However, it's not the same. It can be same in, you know, CO equals MIP could be in 5% of the cases, but more than 95% of the cases, it's not the same. And if you look at the definition, and this is the document I would recommend. It's freely available. It's called Glossary of Prosthodontic Terms 9. And as you can see the link at the bottom, but if you Google Glossary of Prosthodontic Terms 9, you'll find a PDF version of all the terminologies you need to know about occlusion. I would recommend you to read that rather than believe someone else's definition, because that definition is been debated and then published by an authority or people who really know what they're talking about. But even if you look at the definition of this Glossary of Prosthodontic Terms, definition of when they published the first document, the definition of CO was different than the definition of CO what is now. And that's why Let's say if you're talking to someone who's been teaching for 30 years and they haven't updated their knowledge, they might say centric occlusion is the same as maximum intercuspal position, but it's not, and the definition has changed. Just to recap, the first thing you need to understand is centric relation, which is teeth apart position when your condyle is most superiorly placed and in the jaw is most relaxed position. Centric occlusion is when your jaw is closing from that relaxed position and touching the tooth. The first tooth usually is the first tooth. And that first contact is called centric occlusion. Now, in only 5% of the patients, the first contact is all the teeth coming together. It's maximum intercuspation. However, in 95% or over 90% of the patients, it's only one contact, and then the jaw slides forward. And I'll show you some videos on how that happens. But the jaw slides, and that's why we call, this patient has a slide. And patient then goes to maximum intercuspal position. So these are the three terms. Have a read through and make sure you are used to using these terms, because there is a lot of confusion about that. The other reason is that, conformative dentistry works very well most of the time, and that's why I've seen many courses where people don't, even if they are opening up patient's bite, they will just, restore the teeth as the occlusion patient had, and then just adjust it. So because conformative dentistry works very well, and if you many times put the restoration a little bit high, patients tolerates it. Most of the patient tolerates it. They don't really feel it, and then the bite will adjust by itself. The whole concept of DAL, where you are really building only front three teeth, and then other teeth you're just letting them move around, is based on that concept. And that's why many dentists don't really take time to learn about the occlusion. And obviously, at the end, there's a lot of practice needed. You can't just read books or do online courses. You need to go on hands-on courses, and then you need to really practice it at your practice, because what I've seen many times is the dentist who really practice occlusion consciously, they then start seeing things, and then they learn more. And this is with anything what you learn. So the warning signs you need to look out for occlusally, challenging patients is when you ask patients to really close their teeth. You can ask them bite together, and the patient takes a little while to locate that teeth and close together. If that happens, then you need to really think twice before doing anything complex in that patient, because patient's muscles are so tense that, or patient cannot locate the bite much more comfortable to them. Then if you keep seeing patients for multiple broken teeth, and the worst one is the patient complains of the pain near their jaw joint, I would not really restore that patient until the pain eliminates. And you can do various things, exercising, muscle relaxation, Michigan splint, or some sort of a splint or deprogrammer. But I wouldn't restore. Obviously, you can do a provisional restoration to make sure the cavity has been filled, but no definitive restoration until the jaw pain has gone. And obviously, when you see patients like this, heavy bursts, so almost edge-to-edge occlusion, you really need to think twice before just restoring front teeth. This is not a dull case. This is the case where it's a full mouth reconstruction case. So application of occlusion, there are three main applications. So, application one is you can use the knowledge of occlusion during the treatment planning. It's the first thing. So the way you can use this is you can use by diagnosing issues related to the failure, which we're going to discuss about that case pretty soon. You can mount, model, and assess. You can also mount, model, and assess the first point of contact and that particular slide which will then help you, because if you are treating that tooth with the first point of contact, and if you eliminate that first point of contact, then you will lose the space which you created. And that's the reason many times you prepare the second molars and you lose the space of the crown, because the jaw has repositioned itself. So basically you've done equilibration. Assessing trouble cases, when you do proper occlusal assessment, you will be assess the patient which dentition looks a bit difficult. You can plan for long-term stability, and again, you can plan for failure. The way I plan for failure is by incorporating guidance. So let's say I've treated the case for canine guidance, but I know that if I build the palatal aspect of the canine with composite will wear, and eventually the patient will end up touching other teeth. You can do two things. You can either review patients obviously regularly, and 5 years down the line, if the patient has worn that down, you can rebuild that again. Or what you can also do is you can plan on your models that if the canine guidance wears down, where the guidance is going to go, and you can pre-build that guidance into group function. So you can make the buccal cusp of the palatal incline of the buccal cusp of maxillary teeth in such a way that once the patient has worn down that composite of the palatal surface of the canine, the guidance is automatically picked up by a premolar and not the molar. And that can be done by assessing the models on an articulator. In routine dentistry, definitely occlusion will increase your predictability. It reduces the appointment time, which is really important nowadays because AGP procedures obviously taking so long time to sort of turn over. Reduce the risk of the failure due to fracture, hypersensitivity because of the heavy occlusal load. You will be able to manage broken teeth much more predictably because of the knowledge of occlusion, and you can do multiple restorations without changing the OVD. And obviously in advanced dentistry, you have ability to increase or decrease patients' vertical dimension. So let's discuss about today's topic, occlusal management of anterior restoration. So whenever you're doing, or whenever I'm doing any anterior restoration, I do this 6 checks very quickly to make sure that I'm safe to do that restoration. So first thing I would check is whether intercuspal position, maximum intercuspation is stable or unstable. If it's stable, yes, you go ahead with it. If it's unstable, then you need to make sure that you assess that properly before you start doing any multiple restorations. Because if it's unstable, the patient may need full mouth reconstruction. Patient may need they may have some issue with the jaw joint. But you need to really decide, or if patient has very less teeth, there is lack of posterior support, and because of that, patient's got unstable dentition, I will be very wary doing any anterior restoration until patients has some posterior support. You need to assess CO to ICP slide and make sure that when jaw is sliding forward, it's not hitting the anterior teeth, and that can happen many times where you're doing veneers on the anterior teeth and patients sliding forward when they're grinding or when they're closing their teeth, and they're hitting those centrals, and then they're knocking the veneers off. Check the lateral guidance, make sure that you know where the guidance is at the moment. Even if it's on the molar, usually we prefer between canine to premolar. But let's say if patient's upper right 7 tooth is guiding on lateral guidance, if it's a natural tooth that's been like this for a long time, I wouldn't change it. It's not a disease to have a either non-working side contact or working side posterior contact. But you need to be aware of it. If you're restoring that tooth, I wouldn't want to incorporate non-working side contact or a working side guidance on a molar. I would rather take it off and use other teeth to build the guidance. Check protrusive guidance. Again, when you're checking protrusive guidance, you're checking how heavy it is, how many teeth are involved. Usually it's better to spread the occlusion out when it's involving protrusive guidance, especially when it's between 2 to 2. Non-working side contact, as I said, it's purely to make sure that if you're restoring those teeth, then make sure that you don't incorporate non-working side contact into that. And check the functional movement. This is something I didn't used to do before I studied functional movement. And many times what you see is when you ask patient to grind forward, lateral, excursion, and everything's fine, patient comes back and they start breaking one side all the time, something. And what happens is many times when patient grinds, they don't grind forward, backward, or side to side. They grind in eccentric movement. They just grind in and out, either up and down, in and out, and it's a different various position. And what I've started doing some years ago is I started asking patient to probably chew on a wet cotton wool, sort of a small pledget, and see how that chewing pattern is. Because when they're chewing, and if my restorations are hitting when they're chewing, I need to think about adjusting them. So I would put the cotton wool, cotton pledget on one side, put articulating paper on the other side, and ask patient to chew and check whether they're hitting on one particular tooth. And sometimes patient will tell you, oh, it's hitting that tooth, and you can really adjust it. Even though the lateral excursion and everything's fine, because when they're parafunctioning, they're really hitting that tooth. So if anything, that's really important for you to assess. So when you are restoring, let's say, anterior teeth, whichever teeth are guiding teeth, you need to first decide that if you would like to build a protrusive or lateral guidance on the teeth. The reason behind that, let's say if you're treating a canine, patient's got edentulous arch, edentulous space in the canine area, you place an implant and you put a crown on it. I personally wouldn't want my canine to do a lateral guidance. It would be just an ICP contact point, and then lateral guidance would be from on the premolars and probably medial cusp of molar. So you need to first decide whether you want to involve that tooth. So if you're doing post and core on, let's say, central, you wouldn't want that tooth to be involved with anterior or protrusive guidance. So you need to make sure that you have decided, first of all, whether you're going to incorporate any guidance on that tooth. This is a very important that you visualize it. So ask patient to close, ask patient to grind forward, sideways. And many times in the practice, what we see is when you ask patient to close and grind forward, they open their mouth and then you go forward, and then you get frustrated. So what I tend to tell patient is make sure you close your teeth, make sure the teeth are always in contact, and now move your jaw forward without lifting the teeth out of contact. And you have to be patient sometimes because they're usually not used to doing this, and you're now asking them. But visualizing the guidance in that area where you're preparing is very important. Always make sure that you prepped any tooth, check the guidance after prepping, because many times what people do is they would prepare the tooth and then check the preparation, make sure that in ICP they have done enough reduction. But many times people forget to check occlusion in dynamic situations. So rather asking patient to move their jaw sideways, you will see if there's any cusp coming into close contact of your prep, and you might have to adjust either that cusp because it's a plunger cusp or your prep. So make sure that you not just check your reduction on vertical, just patient's closing, but also dynamic movement. Okay, so that's really important when you're doing any indirect restoration. If you're doing direct restoration, then if you're not really sure, then maybe slightly overbuild composite and then directly adjust it to make sure you get nice smooth path. If you're doing indirect restoration and you are going to incorporate guidance in that tooth, then mounting model on a semi-adjustable articulator is best way forward. After you have treated any teeth with the guidance, make sure you make the patient upright and check one more time. Because again, you would have noticed in your practice that you've done all that clear adjustment, and then you lift the chair up, patients rinse their mouth and say, I can still feel there's something proud, because their jaw position changes when the patient's sitting upright, and that's their relaxed jaw position. So relaxed in the sense that they're forward, posturing forward, and that's their normal jaw position. So you need to adjust your restoration in order to fit into that position. So let's look at a few cases. I have 6 cases to discuss, and I'll try and go through them one by one. 4 of them, first 4 is applicable in general practice, and the other 2 cases which you think about and start learning if you're not doing full mouth reconstruction. It's a good way to know how to restore anterior teeth. So the first scenario is a very simple case. The patient comes with a chipped incisal edge of the central incisor. Now you're planning to restore it. Would you need to worry about occlusion in these cases? Probably not, because patients, what you can't see from here is slight anterior open bite. The guidance is way away from it, so you don't really need to worry about it. However, if you are now treating, patient says, okay, I want veneer on upper right tooth. Now, obviously, this is an ortho patient, so I wouldn't do veneer, but let's think about hypothetically. If patient wants veneer on upper right tooth, that all of a sudden becomes a bit more tricky case, because the occlusion is very tight. You don't have much space to increase the length of that tooth. And this is how I would discuss with patient. I would say, look, the tooth is not in an optimum position. Many times we need to do orthodontic treatment to put the tooth in a proper position before we build them. So this is the case where you would need to communicate with patient. If you are doing veneer, then the option is either to conform in the sense that make sure that you keep the same shape but bulk it out a bit buccally. If you're increasing the length, then the only way to do that is reducing maybe the canine a little bit, but that wouldn't look nice with the lower arch, or possibly building up an anterior guidance using the canine ramps, which we'll go through later. However, in any case, it will be a compromise, and I wouldn't advise that. So if you are treating the upper right tooth, the patient really needs an orthodontic treatment. So this is after we simply restore the incisal edge. Pretty straightforward restoration. It's nothing difficult. Now again, this patient is a post-orthodontic treatment. So we finished orthodontic treatment, and now patient wants incisal edge correction. Would I really worry about treating this? Not really, because again, patient's got good overbite, and the guidance is going to be more on her natural teeth and then coming on to the restoration. So when you are planning or building a guidance, you need to make sure the same thing with this case where patient's got nice overbite. So when you're building a guidance, you need to make sure that there's enough tooth to guide initial guidance before the guidance goes into your restoration. Okay. However, let's look at this case where patients got after again post-orthodontic treatment, patient wants veneers for 2 to 2. Now this becomes a little bit tricky because you're going to increase patient's incisal length on the laterals. And when you come to do veneers on the laterals, you need to make sure, A, patients, after your preparation, when you fitted the veneer, the lower tooth is either contacting fully on a natural tooth, that's the ideal. And if the patient's grinding forward and the teeth are sliding onto the veneer, I'm not really overly worried because I'm very confident with my bonding technique. But I'm more comfortable if patients biting on the natural teeth, ICP, and then the jaw movement happens and slides onto the veneer. But if this is not possible, I would rather not have that contact point at the junction where the veneer meets the tooth on the palatal aspect. So either I would go beyond that ICP contact point and have the whole contact onto the veneer, which is palatally wrapped now. By this time, it will be almost like a crown, or on the tooth. I wouldn't be comfortable having it at the junction. But otherwise, I'm very comfortable in having a guidance on my veneer because I'm very comfortable with the bonding. I always do IDS, immediate dentin sealing, try and keep it on enamel. And now we can do, nowadays with the bonding agents, we can do really good predictable bonding. The one thing you don't have, you cannot see from this photograph properly is patient missing posterior teeth and only have 4 to 4 in lower arch. Now, this patient, I had a chat with her and I said, look, I cannot do veneers unless you have some posterior teeth to give a bit more support to anterior teeth. And that's the reason she was wearing her front teeth anyway. So when I'm seeing this wear, I know we have shortened dental arch. I mean, in this case, patient has 8 pair of teeth, not 10. So it's less than shortened dental arch. But let's say patient has 10 pairs of dental pairs of teeth, so 5 to 5 occlusion, but they are all very worn down. And that suggests that the patient really needs a posterior support. On the contrary, if patient has 5 to 5 teeth and they are pretty much immaculate, not much wear, not much chipping, then you can leave the patient like that. It's not because patient's tolerating it really well. So you really need to assess patient by patient what type of occlusion you're looking for. And obviously that's what we finished with. And then a patient had already implants placed posteriorly. So let's come to the case in this one. Again, coming back to this case where a patient repeatedly broken upper left tooth. As you can see carefully, if you look at the canine relationship on the left-hand side, you will see a massive gap. So what was happening is when patient was doing the lateral excursion, patient was guiding on that tooth, that lateral incisor. And the lower tooth, was the canine, like you can't see in this photo, but you'll see in the models, was quite sharp. And because of that, patient kept flicking or breaking that restoration. So let's look at the and the reason why the canine wasn't guiding, because it was twisted, and it wasn't in the correct position. So just a quick recap why we want canine guidance, because first of all, canine have a crown root, favorable crown root ratios, long root and a shorter crown. It remains for longest, most of the canine last long. More PDA also, it's got more proprioception. Palatal surface is ideal into building a guidance because it's got concave, convex, sort of a guidance and sort of a surface. And mechanically, it's in a favorable position because we know that the further anterior you are, the less force you will apply on your muscles if you're parafunctioning. So we cannot stop patient parafunctioning, but we can, when they are parafunctioning, we can alter the effect it has on them muscles to break the cycle. So we know that this is the This is the fact that the further away you go from the TMJ, the lesser the impact of the forces. And again, it's been proven by lots of studies. However, there has been a papers which has said that this is not the case. And you know what? I'm not really worried about that. For me, it's the simplicity that managing one tooth is very simple than managing 3-4 teeth at a time for guidance. So, but I'm not stuck up on canine guidance. It's a very easy method to follow and more predictable. So what we did was we mounted the model. I did wax up myself, mounted the model myself. That's a bit scruffy because I really want to assess and evaluate the teeth. So we were planning to do 3 to 3 for 2s and 3s, upper right 2, 3, and upper left 3 composite bonding, and then upper right 1, upper left 1 crown, and upper left 2. I told patient that, look, I mean, it's the tooth is really now on its last leg, so we will decide, we'll temporize it, and then we'll decide what to do. Most likely we'll need removal of the tooth. However, whatever we put in that place, let's say we've done implant and a crown, it will have the same fate. So we really need to assess the occlusion properly. So once we mounted model, what I've done is I've then built on the model with the wax up guidance. So I added composite on the palatal surface of the canine on the right lateral and canine, because upper right 1 is also the post, and I didn't want guidance on that tooth. And upper left 1 had was root canal treated, so again I didn't want the guidance on that tooth either. So on the left hand side, my lateral and protrusive guidance was both in canine, and that's why you can see 2 mark on your left, on your right face. It's a mirror image. So, and whereas patient's right, I had lateral incisor and canine doing both movement. So lateral incisor was in a good shape, and so as the canine. So I used both of them for the guidance. And this is very easy to do nowadays. With the what I tend to do is I would have a wax up done with the occlusion you want. And the way they need to do wax up is the technician needs to mark the ICP contact points on the model and build the wax incisely to that contact point. So you're really not changing patient's OVD, because patient can still close in that contact point because there is no composite. But incisal to that, you have bulked up the tooth. When patient slides, it hits the composite and it discludes much quicker. And what you then can do is use a clear indices using either Memosil or GC's material, where it's a clear bite, where bite registration material. You just pop it on the model, and then put the composite on that stent which you made, put it on the tooth, and then cure it, obviously using appropriate bonding technique, and you have it. So it's pretty simple to do. What I would suggest is, before you do that, make sure you mark the ICP contact points on the teeth, all the teeth, posterior and the teeth you're working on, so that if there is a little bit more flow of the composite onto the ICP point, you will be able to adjust it. So the patient doesn't, you're not opening the bite up. But it's pretty simple technique to do and use it. So by doing this, we managed to treat the patient, and patient was happy, and it was predictable. This was 5 years after we treated him, and everything's stable. And that's what we really want to achieve after we are doing. And while we're doing that, this is something you really need to understand the slide. So as you can see on the left hand side, there is one tooth in contact, and then when the jaw moves forward, it pushes the anterior teeth. And this is a bit better explained in this video. As you can see, this patient is trying to close. And then when patient slides closes completely, the jaw slides forward. And that's something you can see if you're doing anterior restoration, and that's very important to make sure that you note that in your notes. The other cases, this is another scenario where you have a anterior restoration chipped and patients really got a deep bite. Now you might be tempted to restore this teeth. The problem is patients got really heavy palatal wear. This is actually the easiest case to manage when you're looking at a full mouth reconstruction. So we literally mounted the model and wax up, mock up, upper lower anterior definitive restoration, posterior temporaries, and then the final. So you can see before and after where we restore. But when you come and when you see these kind of cases, we need to really communicate with patient, because this patient came to see me just because she had anterior chipped teeth. She was very conscious of that. And she just wanted that fixed. She didn't want anything else. But by educating patient, she started, we managed to treat her very conservatively with direct composites. The other case where you can change or alter anterior guidance is a little bit by using a lateral thinking. So this patient came to see me because he had a severe wear just on the posterior teeth. So 5 to 7 severe wear because of his the way he was grinding, and initially the habit he used to have a fizzy drinks, but surprisingly, it did not do any damage to 3 to 3. So the canine to canine teeth were pretty much intact, upper and lower. So what we ended up doing is just restoring the posterior teeth. And because he had the crowding anteriorly, so when we restore posterior teeth, obviously you're opening up the bite even more. And now we're basically doing an Invisalign to make sure that we then move the jaw, close the jaw and get that anterior guidance, but at the same time correct the occlusion of the patient and the crowding of the patient. So that's the end result for that patient. So your aim should be to really see these cases and then see the end result once you finish learning occlusion, which is never finished. So you're continuously learning, but your aim should be to try and see these kind of rare cases and see the result and communicate that with patient and be able to do it in your general dental practice. And this is not a rocket science. It's pretty simple to understand. So I'm done here. I hope you enjoy the webinar, and if you want to get in touch, feel free to ask me a question and email me or contact me via Facebook, Instagram, or visit my website.
Thank you, Dev. That was a wonderful presentation and a great summary in a short period of time. So I've got a couple of questions that have come in. First question I have from Dr. Mrigana Sankar. Does occlusion cause obstructive sleep apnea?
That's a very, very good question, because in America, people are really hot on occlusion and sleep, and it's the other way around. Actually, they're thinking that the sleep causing the issues, occlusal issues as well. It's very early on to say that that does affect. There is some evidence, but the jury is very much out. But in America, it's definitely a trend where people are, so-called occlusionists, or people who really treat the occlusal cases. They are liaising with sleep clinics in order to work with them together and get the patient's sleep right, because I've certainly treated a few cases where there was occlusal issues and patient sleep was very it was affecting patient sleep, and then once we finished, patient was better positioned. But I cannot really pinpoint and say, okay, because of I've done occlusal rehabilitation, patient started sleeping well. But there is definitely a research going on right now, and there is some data suggesting that it is possible.
Okay, thanks, Dev. I've got a question from Alice Chaco. Hi, Dev. How do you build this guidance into protrusive movement? Because when teeth are not in contact, they can bring their teeth into contact for chewing, etc.
Sorry.
How do you build this guidance into protrusive movement?
So same thing again. When you are building the protrusive movement, I tend to build on the model. So you would on the model you will put a wax and mimic the patient's protrusive movement, and I keep it very shallow. So I lateral guidance again shallow, but I'm happy to have a little bit steeper lateral guidance. But protrusive guidance, I keep it shallower because you're putting too much force on the anterior teeth. But you can certainly build that quite comfortably, where patients closing and they have shim stock, sort of a space of shim stock, and that's what I think the person's mentioning, sort of a mutually protected occlusion where you have anterior teeth just holding shim stock when they're clenching really hard, or when they're not clenching, the shim stock sort of passes through. So there is an 8-micron gap, and when they move forward, you start guiding the teeth. So you can certainly build that using direct composite.
So
if you're doing that, go on.
It always fills me with dread when I get a class 2 dib to deep overbite, low angle class skeletal relationship and malocclusion, and the anterior guidance on an implant. So do you balance that, or do you just try to keep the implant completely out of that kind of very steep anterior guidance?
So it's a really good, I mean, I tend to, if patients got crowding, great case for ortho. So I would definitely consider orthodontic treatment. Not that I want all the patient into class 1, but it does help orthodontic treatment. But let's say if you're not also doing orthodontic treatment, if you're just doing one central incisor, then I would not have any guidance on that tooth, because hopefully the other central incisor or the canine is going to disclude it. If you're doing 2 to 2 implants, let's say 4 implants together, I would build the guidance using premolar and canine. So I would stay away from the implant, because class 2 div 2 can put a lot of pressure on implant and damage them. So I try and avoid those cases, avoid guidance on implants on those cases. I would use a premolar or canine to build all my guidance.
Okay.
Even you can use a premolar to build protrusive guidance.
I've got another question from Jose Anthropar. When you have to reorganize, what's your choice to record the CR?
I am quite old style, so I use Lucia Jig and Moico Beauty Wax. But you can use, because I have a technique where I, once patients relaxed, I then use a flowable composite on Lucia Jig to record that position, because after you put bite registration or Moico Beauty Wax and ask patient to close, you're not 100% certain that patient's closing back into that same relaxed position. So I tend to put a flowable composite on that position, relaxed position. The patient just has to slide back into that position. So I know that patient's gone back into relaxed position, and I'm not guessing. But yeah, I use a Lucia Jig and Moico Beauty Wax. Alternatively, you can use leaf gauge and bite registration material, and that's what many people tend to use. The only thing is, if you're using bite registration material, use Buta-D or some sort of a really hard biter registration material. Don't use a very flimsy one. And if you're putting biter registration material between teeth, make sure you don't put too much of it, because trimming it becomes an issue. And also make sure you have thick enough space, so you open the patient's mouth enough to have the thickness of the biter registration material. Otherwise, it will be so flimsy that it will be useless.
Thank you, Dev. I've got a couple more, just a comment from Jose before another question from Jose. Thanks for your time. You did simplify a complex topic. Many thanks. What's your view on direct shaping of occlusion?
Direct shaping of occlusion. If it's on the direct restoration, that's fine. It's literally a composite. You just shape it, and you don't have to articulate models like what I've showed in the case. You can really directly mark the ICP contact points, and then just to build the composite directly, on the same appointment. So it's a little bit more trial and error, but you can certainly do it without even using semi-adjustable articulator. You actually using patient's own jaw as a semi-adjustable articulator. But it is tricky because you're putting rubber dam on, and then you're bonding it, and then you're taking rubber dam out, and then if you put less, then you're going back. And so it's a little bit tricky, but it's not impossible. You can definitely do directly. If you're doing indirect restoration, then I always do something called like a bisque trine or baked trine first, check the occlusion in there, make sure everything's perfect, and send it off, because I prefer not to adjust crown after they're finished. If you do minor adjustment, you can get really good porcelain polisher. Make sure you polish the porcelain really well if you adjusted them.
Okay, thanks, Deb. I've got a couple more questions for you. Do you need a semi-adjustable articulator to change the guidance? Is there any simpler way?
No, you don't need, in the sense that you can just, you don't need to own the semi-adjustable articulator. You can literally use a face bow and send it to technician, let the technician mount the model on an articulator. What I tend to say is, when technicians sending those model back, ask technician to make sure they send the articulator back, because there's no point in sending articulated models without the articulator, because you can't really assess them. So, when they send the model back, make sure they send it with the articulator. You can have a quick look and send the articulator back to them. But yes, you don't need it. And again, if you really don't even want to record Facebook, then you can do directly in the mouth, which I just explained before.
Okay, last couple of questions. Is there any particular type of cases where you should not change guidance without reorganizing?
Yeah, so wear cases, when patients, severe wear, patients bruxist, because sometimes if you make the guidance too steep, they can start doing trauma from occlusion on that tooth. So these are the two cases, when patients got severe wear, like I just showed before, where the anterior two front teeth were chipped, but I did a full mouth reconstruction because it's just not patient's best interest to just have two teeth repaired. They need a full treatment.
Okay, Deb, last question in the last few minutes. What is the quickest and easiest way to assess CO to ICP slide?
So one of the ways is Lucia Jig, where you make a Lucia Jig, deprogram the patient and then check. The other way is bimanual manipulation, but really the easiest way out of all of them is leaf gauge. You don't really need that much tactile sensation. You just use a leaf gauge, and you will know where the first point of contact. Take the leaf gauge out gently, and then ask patient to close, and you will see the slide.
Super, Dev. I think that's the last of the questions. Thank you once again for simplifying a very complex topic. Even I find it hugely interesting as a head and neck surgeon. We really appreciate your time, and have a good evening. Just to finish off now for the participants, the next webinar on the 13th of April will be by Professor Chris Deary, and he will be discussing caries diagnosis and management, and I look forward to seeing you all for the next webinar. Have a good evening. Bye-bye.